Um, Thanks for inviting me and giving me the opportunity to chair this session. It was interesting to see all these problems about treatment of patients. We are somehow sometimes involved in regard to imaging. It's also interesting to see that once it's coming about cardiac risks, it's only imaging that's involved at the moment. As we're going to talk about several things on CT imaging, and there has been publications about radiation exposure, cancer risk within the last couple of years, especially one last year in the Canadian Medical Association Journal. So I think it's a very timely topic to talk about that because we know what we apply to the patient. We have experts that know what the risk of this might be, and we want to educate on whether we still go on for radiation exposure examinations like nuclear medicine, CT imaging, or angiography. So it's my great pleasure to introduce the first speaker, Dr. Edward Waller. He's an engineer from the University of Ontario Institute of Technology. And I think he will bring up a little bit different perspective on what we look at imaging, because we look from a physician's point of view on imaging, what we can get, but we want to see what the radiation dose really does to the patient. Please.
Okay, thank you very much. Talk about a fish out of water up here in a room full of medical professionals and me. So I've subtitled this talk, Is It Safe? And this is the way we feel sometimes in radiation protection. Is it safe? No, it's not safe. Is it safe? Yes, it's safe. Is it safe? I don't know. What answer do you want? We're constantly dealing with this in radiation protection, and I'm sure the majority of you are dealing with these same types of problems. Is this radiation exposure safe? So I've stolen from Marathon Man here, and I'm going to try to pursue this and try to answer this at the end. I have no disclosures other than the fact that I'm not an MD, I was never an MD, and I never will be an MD. So just bear this in mind. I'm a physicist, engineer. My understanding of radiation and radiation risks is across the spectrum. So I have done work in CT dose, diagnostic reference levels. I worked in radiation oncology for a while, but I'm all over the place. So I'm looking at it with a little bit of a different perspective. I'm not within your system, I'm a little bit outside the system. Those are key messages. Communication is going to be the one that I end up with, but we'll just leave those for you to look at. The way my talk's going to go is I'm going to talk a little bit about radiation dose, get us all on the same page, about risk from this exposure, a little bit about cardiovascular procedures, and then communication with the patient, or what I believe the communication lines should be. I'm going to try to do this in the 25 minutes. So radiation dose, what do we know about this? Well, here are some graphs from the National Commission on Radiological Protection. These are US, this is a US-based organization. And you can see that in their report 93 and 1987, that about 55% of the majority of our natural and human-made radiation exposure was from radon and thoron inhalation, and that medical was about 15%. And that was common in Canada and the US. Fast forward to 2009, and the lay of the land's much differently. 48% of the total radiation exposure now is medical exposure, a great proportion of that coming from CT. And some of it's to be expected. In Canada, we're probably tracking this somewhat, but in Canada, we have a different system. In the US, of course, anyone can hang a shingle, set up a CT scanner, and the GOA in the US has done studies that show when physicians have a financial interest in the clinic, they tend to do more referrals to their own clinics. So there's a lot of other issues that appear in the US that don't appear in the Canadian system. But the interesting thing is that you can see an almost doubling of dose. And this is going up and up. If we break out the medical dose, if we look at the dose in the 80s, you can see that conventional radiography was the major player. And I've highlighted interventional fluoroscopy just because I think that might be interesting to you. You can see that in 2006, computed tomography was almost half of that, and interventional interventional fluoroscopy went from 3 to 14%. So these kind of high dose procedures. Now it's very interesting. I've been working on looking at dosimetry. When you look at the National Dose Registry for, so those of you who have badges, your data goes in. Well, there's only two categories. There's diagnostic and there's therapeutic. And I think the problem with that is that your doses, especially when you do interventional procedures, get smeared out with the lower doses. So I think this is something in the system that has to be fixed. That's a different talk. But I really think we have to break it out more. So what is dose? I don't know if I'm preaching to the converted, but I thought I'd get us all on the same scale. Absorbed dose, it's a physical quantity, energy imparted per unit mass. You can calculate an absorbed dose in tissue. You can calculate an absorbed dose in a rock. You can calculate it in a turtle shell. You can calculate it in a piece of silicon. Doesn't make any difference. It's a physical, measurable quantity. And that's why people often like to talk in terms of absorbed dose, because it's the only real quantity we have. And we use a unit of Gray, and you've probably seen that. You can take that absorbed dose and come up with an equivalent dose. You multiply by what's called a radiation weighting factor. The radiation weighting factor takes all the different types of radiations, highly ionizing alpha particles, neutrons, and what most of you tend to use, which is either gamma rays or X-rays, and puts them all on the same sort of significance scale. Now, for most medical diagnostic procedures, your radiation weighting factor is 1. So you multiply that absorbed dose by 1, and you end up with a new unit called sievert. Now, to make things even more confusing, we then take that equivalent dose and we multiply by a tissue weighting factor. Now, that in and of itself is not confusing. The confusing part is we don't change the name of the unit. So we go from a sievert to a sievert, and again, it's this dimensionless quantity that relates to the sensitivity of the tissue. So very insensitive tissues like muscles will have a very small weighting factor. Very sensitive tissues like red blood cells will have a higher weighting factor. You add up all the tissues in your body, it normalizes to 1. So the whole body dose will be 1. So you can go from equivalent to effective dose with a factor of 1 if you're looking at whole body. So those are the doses, and normally when you see doses, you're either going to see absorbed dose or effective dose. Now, what's risk? That's actually the topic here. Risk is this effective dose times a risk factor. And the risk factor is some sort of percentage endpoint per unit dose. So for example, percent fatal cancers. You multiply the sieverts times the percent fatal cancer per sievert, you end up with a percent fatal cancer, or we often express that in terms of excess relative risk. Now, the conundrum here is that as we move from absorbed dose, which is a physicist quantity, to risk, we induce a lot more error because equivalent dose and effective dose are inferred quantities. Risk is a hypothesis, at least in the low dose regime. If we're looking at deterministic effects like erythema and appellation, okay, that's a different story. But I'm really talking more about stochastic effects. And it's compounding error. So if you go up this scale and if you consider as this arrow is getting bigger, those are error bars. The error bars keep getting larger and larger and larger. If you're wondering, well, does this introduce confusion when I'm trying to communicate to the patient? Absolutely. Even we health physicists were confused about this because we don't really know what the answer is. Now, that being said, we still need to generate dose limits. And what a lot of people don't actually realize is our models of risk were generated to regulate the nuclear power industry. They never had and never should have anything to do with medical exposure, despite the fact that everyone uses those models for medical exposure. They were only to regulate the nuclear industry to have limits that we could control the generation of nuclear power. So what we have set up is occupational limits. What it says in the Canadian regs actually is 100 millisieverts over 5 years, which averages to about 20 millisieverts per year. That being said, you can get 50 millisieverts in a given year as long as your average over the 5 is below 100, if that makes sense. The public we regulate to a lot less because we don't measure dose in public. So basically that dose limit is for manufacturers. So if I decide I'm going to set up a shop that's manufacturing smoke detectors with radiation sources, I have to prove to the regulator that I'm going to be below that 1 millisievert. And then, of course, we have other dose limits to lens of eye, skin, hands, and feet. And of course, patient medical exposure is not considered because we have these mantras in radiation protection. Justification, we justify the dose. Optimization, we optimize the dose to levels as low as reasonably achievable. And in everything except medical exposure, we have dose limitations. In medical exposure, no, because you're assuming that there's a net benefit from the exposure. If there is no net benefit from the radiation exposure, you have to think, why am I doing this? So this leads us into a discussion about risk. Well, in risk, we're inherently working with uncertainty. We can't say for certain for a population what the risk is, and absolutely not for an individual what the risk is. So all those risk factors that I showed you are great, but you can't take a patient's dose, multiply it by a risk factor, and say that's your risk of cancer. What you might be able to do in a global sense is say, if I took 100,000 of you and irradiated you to this level, then this might be your excess relative, this is how many people might get an excess fatal cancer, maybe, at the end of the day. And certainly when you're below 100 millisieverts, all bets are off, because we don't have any data that low. Where do we get our risk to humans data from? Well, atomic bomb survivors, Hiroshima and Nagasaki. In fact, it's an interesting thought experiment to wonder what our risk models would look like if we didn't have that data. It would actually look quite a bit different. And then a little bit of data on medically exposed groups, ankylosing spondylitis, and these repeated fluoroscopic examinations, and then some of the occupationally exposed groups, radium dial painters, uranium miners, and former plutonium workers. But those data points are a lot more sparse. Our biggest data set is actually the atomic bomb survivors. And what's our current assessment of risk? Well, cancer is, depending on what group you're looking at, one gender or whatever, between 4 and 10% per sievert. Hereditary disease, 1/10 of fatal cancer risk. That's never been measured. It's never been shown there's any hereditary risk in human populations. This is from Drosophila experiments and inferences from what we get from the atomic bomb survivors, but it's never been measured. And radiation effects on the fetus, lifetime cancer risk of 20% per sievert. Of course, you would assume it's going to be up because they're tiny little mitotic things. And if you go back to the law of Burgundy and Tribondeau, you know that as cells are more mitotic, they're more sensitive to radiation mutations through chromosome aberrations. Again, what we know, and I just said this, well, cancer risk estimates apply to populations and not individuals, absolutely not. Individual risk can be all over the place. And we've seen this on large exposures. You can give one person 3 sieverts, and that'll be a fatal exposure. Another one could get 3.5 and survive it. Or you could give one 1.5 and they would die. So it's always individual. And you can see, interestingly enough, this is attributed lifetime risk in percent per sievert as a function of age at time of exposure. And you can see how it drops dramatically at about 30 years of age. That's got to be taken into account because it drops dramatically primarily because these cancers will never be realized to end of life. There could be a cancer induction, but it's not going to shorten your life because you die of something else before the cancer becomes fully manifest. Large study was done, published in 2003 by Brenner and colleagues, and some of these names might look familiar from past studies. They set out to say what's the lowest dose of X or gamma radiation that provides good evidence of increased cancer risk. The summary of the paper is that there was some data that suggests between 10 and 50 millisieverts of acute exposure, there may be a small elevated risk, and between 50 and 100 millisieverts of protracted exposure, again, a slight elevated risk. When you look at some of their data, though, excess relative risk for the group in different dose ranges, you can see at the lower end of the spectrum, it's not statistically significant. So really, the threshold that I tend to use is at about 50 millisieverts, you might want to start looking at it. Personally, I think that's about 100 millisieverts, but you can make an argument for about 50. What don't we know? So between 50 and 100 millisieverts, we will probably never have the answer to this. I hate to be pessimistic. There will never be an epidemiological study that will ever be powerful enough to be able to detect this, primarily because of the high background cancer rate of, let's pick a number, about 40%. You're never going to see these excess cancers, so attributing is impossible. And we don't have an agreed upon mechanistic model for carcinogenesis. So, those two things coupled means we'll probably never have the answer to this. So what do? Well, again, regulators have adopted a linear non-threshold model. What that basically means is you take all those red dots from the atomic bomb survivors, at some point, there aren't any more points, and you say, I'm gonna make a logical leap that there's zero risk at zero dose, so that gives you a fulcrum point and a bunch of other points. That means you can draw a straight line through it, through the origin. And that's called the linear non-threshold hypothesis. The actual data, if you plot it up, is more like a quadratic. But really, if you look at the data holistically, it's really more of a threshold. Above about 100 millisieverts, we really don't know. And if you look at some of the literature out there, you'll also see that. You'll see a hormetic effect where a little bit of radiation is actually good for you. And I'll try to explain that in a very, very recent publication that just came out. There's a number of models for that. How bad is linear extrapolation? Well, you can look at the percentage incidence of leukemia as a function of X-ray dose, and you can see that it's easy to overestimate, for example, leukemia. It's a linear quadratic at low to intermediate dose, but it saturates and it actually decreases at higher dose because of cell killing. So a linear model clearly doesn't always apply in these risk estimates. That being said, some authors don't mind using the linear non-threshold for medical exposures. This is an article that was in the Archives of Internal Medicine that used the results from the BEER-7 report on linear non-threshold and came up with an estimate of 29,000 excess cancers in 2007 from a 70 million exposed cohort of an average CT dose of 13.8 millisieverts. And for those of you who deal with dose and your eyebrows are raised and saying 13.8 millisieverts, yeah, you're right. That's a low, unrealistic dose. You can work the mathematics out because it's a linear non-threshold model. So the math will calculate whatever you want. You will never ever see those in a population. So you can say whatever you want. It's kind of amazing it got published, really. 13.8 millisieverts, even when we do chromosome aberration analysis, these are a couple of typical metaphase spreads for radiation exposure, and you can see the dicentrics here, the dual centromere chromosomes, that we can't really even detect these in blood until about 100 milligray. Let's say even on the best days, and you've got people that aren't cross-eyed and they're seeing perfectly in a microscope, maybe 50 milligray, maybe. But we're not gonna see down to 13.8, never. People are getting more vocal about this, and I like to take a stand about this because for many, many years, those of us in radiation protection have been a little bit wishy-washy on this. Because we don't know what's going on below 100 millisieverts, we haven't said anything. We like to let the science sort it out. But the reality is we'll never see anything below that level. This is a very recent January 2012 paper by Siegel and Mike Staben. Mike Staben's done a lot of work on inter-utero radiation exposure, basically saying that LNT should not be used for these low-dose exposures, that it should never be used to calculate hypothetical cancers in any population, and certainly not in individuals. And very chillingly, overestimating radiation risks may be more detrimental than underestimating them. And we have actually seen this in cohorts of exposed people. For example, the Chernobyl cohort. You had many, many women that were aborting based on doses they never got of radiation. That becomes more of a psychosocial problem. But at the end of the day, if you're trying to save lives, it's not really doing anything if you're scaring people about radiation. That's the overarching point. This is hot off the press in the proceedings of the National Academies of Science. This is evidence for a nonlinear effect, and it deals with radiation-induced foci. These are repair centers. And what these investigators do, so this isn't just using other people's atomic bomb survivor data, these are actual scientific studies where they've seen these p53 binding proteins, which are indicative of these repair centers. They've actually seen more of them and more of these repair centers at lower dose compared to higher dose, which tends to belay the fact that at these lower doses, there's these repair centers where the DNA strands that have had damage go there and get a new tire put on their car, and then they come away clean instead of mutating into a cancer. So there's actually evidence that low-dose exposure might have a hormetic effect. And again, this is hot off the press, so this is obviously actively being studied. So we work with uncertainty in this. Well, what can we do about this? Given the fact that I said there's a lot of uncertainties. Well, we have to justify high-dose procedures. So justification, optimization, but not necessarily dose limitation. I don't necessarily think that's appropriate. We have to be aware of the increased sensitivity of the young, for obvious reasons, they're little mitotic cells. Should be a better tracking of medical exposures, especially if people have a possibility of getting repeat examinations. And you are seeing these concepts of dose passports where the patient will carry around. The military already does this. I've had many discussions with special forces. They carry it around an RFID tag, their entire history for their entire time in the military. And you can see that at some point in the future, we'll probably all have this, our dose history encoded in something. And also to set measurable standards of exposure for higher dose procedures and so-called reference levels. Now, how do we do this? We look at what people are doing for a given protocol and procedure. We collect all the data for that protocol and procedure. We analyze the data, and at the 75th percentile, we say that's the reference level. And what you do now is you track against that reference level. So say if you're looking at a dose area product or a committed dose. So you have your dose indicator, dose area product, Kerm area product, maybe fluoroscopy time, whatever you're doing as a function of time. That's your reference level, and your QA people just track it. Track it. Oops, it's starting to go up. Then you say, well, maybe this procedure isn't optimized. What's changed here? Has something in the training changed? Has this piece of equipment changed? Maybe we have to re-optimize. Has the average size of the patient gone up? Anyway, do something to see if there's either a renormalization required or it has to drop. So again, back to Dr. Zell and Babe, care must be taken with high-dose procedures. Well, setting up these reference levels are important, and in many cases, the Europeans are light years ahead of us in North America. They've been doing this for years. Setting up for different procedures, so coronary angiography, PTCA, and electro procedures, different reference levels. So again, that facilities, when they're doing these types of procedures, can monitor against these reference levels and see if they're drifting off of them or if they're okay. This was one study in a Greek center where they looked at these 75th percentile doses and before they trained the radiologists, and then after they trained the radiologists on dose reduction procedures, which of course dose reduction procedures are good for the patient and for the interventionalist. And they found that when they retrained their people, they snapped right in line with the expected reference levels that they get. So training here is the key, training on dose reduction principles. So finally, I want to talk a little bit about communication and risk, because there's lots of things out there. Unskier says, well, here's some data. Somebody, please figure this out. Lucky, radiation hormesis, little radiation is good for you. NCRP, well, we're going to evaluate the linear non-threshold model. We can't figure it out, so we'll just leave it the way it is. And Beer 7, well, we don't know what it is either, but we'll keep it linear because we don't know any better. So we have to get the story straight on this. On one side of our face, we're saying procedure's low dose, but low dose radiation can cause cancer. Some people say that. But the benefits outweigh the risks, and we can't detect these anyway. We're never going to see them in the population, so what do we do? Well, the thing that I like to look at is people have an instinctive feel for risks of everyday living, so why not use this when you're communicating? And I've done some comparative risks, and you've probably seen all kinds of different comparative risks. For example, if you look at radiation risks, fatal cancer, using linear non-threshold, these are not observables, these are only theoretical, that there's about 1.23 times 10 to the minus 7 per 3 microsieverts. And I put these so they would all be on the same order of magnitude. Smoking fatal cancer risk and driving fatal cancer risk. If you look at these, realistically, 3 microsieverts is about equal to 1 cigarette, is about equal from driving to here to Downsview in terms of fatality risk. 1 millisievert, which is what we regulate the public to, about 333 cigarettes from Quebec City to Vancouver, and then 8 millisieverts, which is a typical reference for a cardiac angiography, 67 days of smoking 2 packs a day, across Canada and back 3 times. And if you want to even look at a more conservative, well, a nuclear worker dose limit, and when we regulate nuclear workers, we regulate them to the same risk level as a normal occupation, and most people have jobs. their dose limit is 20 millisieverts per year. And in fact, we still say it's safe if we take them to 50 millisieverts in a year. So if you're consulting someone on a certain procedure, here's how much dose we expect, you can use these types of comparisons to give them a concept of relative risk, as an example. I'm over time now, so I'm just gonna go. There's some checklists for the patient and family physician. So if you're above 1 gray, or you could even say 2 gray, you're gonna have to be more cognizant of deterministic effects like burns. If you're above about 100 milligray, you wanna consult about the very low but possible stochastic effects like cancer induction. If there's multiple procedures, they certainly should be tracked. And also, the final point is small risk, great benefit from this procedure. That should always be underlying. And then again, for interventionalists, train on risk communication, basic and continued training on radiation protection, and also on reference levels. So I'm almost done here. The original question was, what's the risk? Well, the reality is radiation is one of, if not the weakest carcinogen on the planet. You can almost not find a weaker carcinogen than a radiation exposure. Doses below about 2 gray should prevent deterministic effects. There's different sensitivities, but it should. Risk from low-dose radiation are comparable to other risks that people assume every day happily in their lives. And the risk is extremely low. Or in other words, to be very definitive, it is safe.
Thanks for this very brief, nice overview in terms of what we can actually tell the patient about the risk. I know it's hard, and we're going to see a lot of things out there in publications as well, because we're dealing with radiation daily routine. I'm pretty sure that we're going to have a very exciting panel discussion later on about radiation again, and thanks for the moment, and see you later on in the panel.